I'm Dr. Buchi Nwaokolo, and I'm a psychiatric mental health nurse practitioner and also a family health nurse practitioner. So today, our topic is going to be talking about understanding schizophrenia as it relates to women. So welcome everyone, and thank you for joining us today. I'm excited to dive into this important topic of understanding schizophrenia in women. Schizophrenia is a complex mental health condition that is often misdiagnosed and is also misunderstood and stigmatized, especially when it comes to how it presents in women. My goal today is to provide a more nuanced and evidence-based perspective. So we'll explore the early warning signs of schizophrenia that may manifest differently in women compared to men. I'll also share insights on gender-specific treatment approaches that can lead to better outcomes. Most importantly, I want to help break down the harmful stereotypes and stigma that too often prevent women from accessing the compassionate, high-quality care that they deserve. Everyone deserves to have their experiences validated and with dignity. So throughout this section, I will draw on my experience serving in the rural and underserved communities where access to mental health care can be challenging. My hope is that we can all live here with better understanding and better equipped to advocate for more equitable, trauma-informed support. So what are the learning objectives for today? The learning objectives for today's section are critical for providing high-quality, gender-sensitive care to women with schizophrenia. We'll start by exploring how the presentation of schizophrenia can differ in women compared to men, including unique symptom patterns and differences in the time that this illness presents. Next, we'll dive into applying the DSM-5 treatment diagnostic framework with a focus on considering lifespan and hormonal factors for accurate assessment. Then we'll identify evidence-based pharmacologic and psychosocial interventions that are tailored to the needs of women with schizophrenia. Finally, we'll discuss practical strategies that combat the stigma that women with schizophrenia often face in clinical settings and their communities. Throughout the session, I will emphasize the importance of integrating scientific knowledge, clinical wisdom, and cultural sensitivity to deliver the best possible care. Epidemiology of schizophrenia. The prevalence of schizophrenia approximately affects about 1% of the global population. It seems even more common if you are in the psychiatric or in the mental health environment. But women exhibit distinct onset patterns, symptom trajectories, and psychosocial influences compared to men. Women also have delayed onset, typically starting 3 to 5 years later than men. Most of the time, we're seeing women present with schizophrenia between the ages of 25 and 35, but that does not mean that we cannot see this presentation in adolescents. So this delay is thought to be related to the neuroprotective effects of estrogen prior to menopause. So some functional outcomes, let's talk about functionality in women. So while symptoms, severity is comparable, women tend to maintain better social and interpersonal functioning, possibly due to the gendered social roles and stronger support networks. Clinical implications. Clinicians must remain vigilant and avoid underdiagnosing middle-aged women whose symptoms may mistakenly be attributed to stress, menopause, or personality traits. So we need a comprehensive, unbiased assessment. And this is essential for early detection and, of course, early intervention when it comes to women living with schizophrenia. So early recognition and DSM-5 criteria. So women with schizophrenia often exhibit a distinct clinical feature that can complicate diagnosis and delay appropriate treatment if not carefully assessed. So let's talk about mood. Mood-related positive symptoms. Women are more likely to present with affectively charged psychotic symptoms. For instance, in men, we can see significant symptoms like distinct paranoia. We can see distinct disorganization and delusions. But in women, their delusions may be affective in nature. We begin to see women in relationships having beliefs of betrayal. Either they think that their partner is cheating on them, or family members are spying on them, or just getting into their business. So paranoid delusions with these relational themes, warrants, a careful look instead of dismissing those symptoms. Auditory hallucinations involving familiar voices or family voices or caregiving commands or critical messages. Sometimes we even see religious or mystical delusions, such as divine communication with God, extended prayer sessions, or spiritual persecution. So these features often overlap with mood disorders, increasing the risk of misdiagnosis, particularly with individuals dealing with bipolar disorder or major depressive disorder associated with psychotic features. So now let's talk about under-recognized negative symptoms. In women, this may appear and can be easily overlooked because an individual who is presenting with negative symptoms of schizophrenia might begin to isolate herself, in subtle ways that is socially acceptable. Social withdrawal may be misinterpreted as depression or introversion. Blunted affect can appear mild and be missed during brief assessment. Maintenance of hygiene and routines may mask underlying deficits in motivation or emotional engagement. Because women often retain higher functionality in daily life, clinicians may underestimate the presence of severity of schizophrenia spectrum illness. So what about hormonal influences in women of either childbearing age or women who are pregnant or who just had babies? So hormonal influence and peripartum vulnerability, associated with estrogen fluctuations across the menstrual cycle, postpartum period, and perimenopause may exacerbate psychotic symptoms or alter how these individuals will respond to medication. So the peripartum and postpartum periods are high-risk periods or high-risk windows for psychotic decompensation, including postpartum psychosis, which is more common in women with a personal or family history of psychotic illness. Diagnostic implication due to symptom overlap with mood disorders and the influence of gender norms or clinical judgment. Women with schizophrenia are at heightened risk of being misdiagnosed. This can delay antipsychotic initiation and delay appropriate psychotic support. So what are our clinical recommendations? So we want a nuanced, gender-informed assessment, a comprehensive gender assessment that is going to include a detailed history of psychotic features across reproductive milestones, either starting from adolescence or during pregnancy, before pregnancy, or after childbirth. We also want to explore that individual's relationship and spiritual delusions. So it's important that it's not swept under the carpet, that every information that is gathered is put in and used as part of that assessment process, or else it becomes easy to miss a diagnosis of schizophrenia in women. Functional assessment beyond the surface level behavior, just for instance, being moody or reduced hygiene or more hygiene processes or cleaning more, has to be introduced. So it has to be an overall picture. If we have to interview family, interview spouses, and determine if there is a significant clinical difference that this woman or this individual has been experiencing. So it can be some challenges, women would often face challenges, especially when they are living with schizophrenia. So gendered stigma and trauma histories with women living with schizophrenia frequently face, is usually a big issue. So as individuals with severe mental illness, and as women navigating societal expectation, many report histories of childhood trauma or abuse, which not only increase their vulnerability to psychosis, but also affect how these women are going to trust us as providers, to engage in their care. So delayed diagnosis and symptom overlap psychiatric symptoms in women, and it often resembles this mood disorder, leading to frequent misdiagnosis as major depression or bipolar disorder. This diagnostic ambiguity contributes to an average delay of 2 to 4 years between symptom onset and appropriate treatment. And this is very important, because when we miss diagnosis early and we leave these women to struggle for years, then their prognosis becomes questionable. So an interval associated with, and this interval is going to be associated with, worse long-term outcomes. High rates of comorbid mental health conditions. Women with schizophrenia are more likely than men to have co-occurring diagnoses. They might experience anxiety, depression, PTSD, post-traumatic stress disorder. Some of these women have co-occurring eating disorders. How about borderline personality disorder? So these comorbidities, they complicate pharmacological management because we're busy treating anxiety and treating depression and PTSD and not looking at that diagnosis of schizophrenia. So because of all these commodities, it's important that we integrate, and we make it a priority to do extensive assessment to be able to diagnose individuals who are living with schizophrenia and provide that diagnosis for them so that it can necessitate integrated therapy approaches. Caregiving roles and functional outcomes despite their illness. Many women maintain their responsibilities as mothers, as daughters, and as partners or spouses. While this adds to stress and emotional burden, studies have also shown that caregiving roles contribute to improved social functioning and structured routines, enhancing recovery in some cases. But that does not mean we're not going to pay attention to women who are actually struggling with this caregiving role and mitigate and figure out how we can better serve this population and manage their disease more effectively. Reproduction health consideration. Antipsychotic medications may impact fertility. So it's always important that we educate our women, we educate our families as a whole. Because when we present with women within that childbearing age, we're looking at between the ages of 12 and 51, and who are presenting with symptoms, it's important that we provide adequate education, because your education would determine how aware they are and how they are able to stick to treatment and management, and of course, tell you when there are changes in their status. So antipsychotic medication will impact fertility most of the time. It may increase menstrual irregularities, and of course, cross for lactating mothers, it might cross that barrier and babies begin to receive this medication through breast milk. So the pregnancy and postpartum periods are particularly vulnerable times for relapse, especially with those who have already been diagnosed. And it can start as an onset for individuals who has never been diagnosed with schizophrenia. So we might see that initial onset of psychosis requiring specialized perinatal psychiatric care and collaborative planning with obstetric, so that we can manage those women who are actively pregnant, lactating, or those who are experiencing first psychotic outbreaks. So pharmacological treatment. So dosing, when we want to manage women, it's important that we pay attention to dosing and sensitivity. Women generally have a higher serum antipsychotic levels due to differences in metabolism, body fat distribution, and estrogen modulation of hepatic enzymes. So for women, we always want to start them at the lowest effective dose possible, and then we want to gradually titrate to minimize that side effect and enhance tolerability. Metabolic risk of olanzapine and clozapine. These are very good medications that we often prescribe. But these two medications carry a higher risk for weight gain. So even while we're managing our patients, it's going to be a holistic approach. We want to be able to have that personified rapport, understand what are their concerns. Because it's important, if you have a woman who is concerned with her weight, to put her on medications that are going to increase her waistline. So some medication, just like olanzapine, will carry a high risk of weight gain, dyslipidemia, and insulin resistance, especially in women. So we want to use preferred alternatives. And those preferred alternatives will be either our aripiprazole or lurasidone when weight management becomes a priority. So even when our patients or these women are on this medication, we want to educate them on lifestyle modification. We also want to have routine monitoring of their BMI, check their waist circumference. We also want to check fasting blood glucose level. We also want to check their lipid levels, using the American Diabetic Association guidelines. Reproductive health and prolactin. This is really very important because when we are treating individuals with schizophrenia, especially when they are presenting with positive symptoms, and you remember your positive symptoms are going to include disorganized speech, paranoia, and delusions. And when this individual presents, it's so likely that they are going to be treated with antipsychotics that are going to mitigate that positive symptoms just to bring them back, to a comfort level. And especially if this individual has been hospitalized, there's a tendency that they're going to be treated, depending on the significance of that delusions or disorganizations or paranoia will determine the amount of antipsychotic medication that might be given to them. So when treating women, we want to pay attention that we're blocking dopamine, which has been associated to positive symptoms, overactivity in that mesolimbic pathway. Overactivity of dopamine in the mesolimbic pathway has been attributed to positive symptoms associated with schizophrenia. So the aim is to reduce that dopamine activity in the mesolimbic pathway. But we want to remember that when we're dealing with women and we are mitigating that effect of dopamine activity in that mesolimbic pathway and blocking that dopamine activity, we may be causing more issues in the tuberoinfundibular pathway. Because when dopamine has been blocked in that mesolimbic pathway, and it's going to get blocked in all the other pathway. And in that tuberoinfundibular pathway, we're going to see a rise in prolactin. So, and when there is an increase in prolactin level leading to hyperprolactinemia, especially with a medication, Risperdal. Risperdal has been a big culprit when it comes to increased prolactin levels in that tuberoinfundibular pathway. We begin to experience menstrual irregularities in women. We begin to see galactorrhea, this milk discharge from the breast. And of course, reduced fertility. We also experience low libido level. So it becomes significant that we monitor prolactin levels regularly, especially in women of reproductive age or those who are trying or planning for pregnancy. So hormonal augmentation, estrogen supplementation may enhance antipsychotic response during low estrogen phases. And for example, during postpartum or menopause. So selective estrogen receptor modulators, like one example would be the roloxifene. They have shown promise in treatment-resistant schizophrenia when added to antipsychotic regimens. We talked earlier that estrogen kind of have a neuroprotective, some neuroprotection when it comes to schizophrenia, and it also helps to regulate that dopamine. So when we begin to see a reduction in estrogen levels, and these individuals are experiencing schizophrenia symptoms, and estrogen, a medication that might help boost estrogen may become necessary as adjunct treatment. So sometimes we're having, because of, we might have individuals who are not responding as much as we would like them to, either because they are not adhering to the treatment regimen. Then it becomes necessary, to introduce injectables, which could be monthly, just to improve adherence, especially during peripartum periods, and women who are also managing caregiving roles, just to assist them through this process. It's important we have these discussions with these women and their family, and then we'll see what's going to fit their treatment, their management, so that we can get better outcomes. So studies have shown that incorporating pharmacological management and non-pharmacological treatments, has been pretty good and effective. So non-pharmacological management of schizophrenia is going to include cognitive behavioral therapy for psychosis. This helps women women reframe gender-specific maladaptive thought patterns. It's going to address some trauma they've had in the past and help them to build some form of resilience. It leads to higher engagement, reduced distress, and improved functional outcomes. Assertive community treatment. This delivers intensive multidisciplinary care in community settings. It incorporates gender-responsive case management to reduce hospitalization, support parenting, and foster independent living. This is particularly very important, especially if an individual has been hospitalized. Usually in the hospital setting, they are presented with a lot of resources. It's important that when these individuals are discharged, that will present those resources within their own community. And this has helped a lot. It helps them get back to work faster. They are able to live independently. It provides supportive parenting, and it's important because you're going to have nurses come in and check on them, see how they're doing with their medication. You're going to have group therapy sessions. You're going to even have therapy coming to their homes, depending on what that individual needs. So ACT is always an intensive multidisciplinary care that it's important that you provide for these individuals when they need it. As a provider, our job is actually to advocate for these women. So let's talk about coordinated specialty care. It integrates psychiatric treatment with reproductive health, childcare support, and vocational services. It targets the complex social and functional needs of women across lifespan. How about peer support programs? They mitigate isolation and stigma by connecting women with peers who have walked the same walk or who share lived experiences. This enhances the role of their functionality and practical coping through modeling and mentorship. How about family psychoeducation? This involves partners, children, and extended family to strengthen communication, reduce caregiver burden, and promote recovery. Well, it also helps with supportive environments. How about social skills training? It focuses on interpersonal effectiveness, emotional regulation, and boundary setting. So all these non-pharmacological aspects is especially useful during relationship transitions, parenting phases, and reintegration into work or education. So we're going to talk about what happens across lifespan. And we're also going to look into cultural consideration, because these are the things that impact women. So we said that we usually will see symptoms in late, either early adulthood or late adolescence, but sometimes we begin to see them early. So adolescence, this is the window of early intervention. If we can detect it on time during adolescence, the prognosis might be better. So schizophrenia often emerges in late adolescence or early adulthood. However, early symptoms during adolescence, such as withdrawal, academic decline, irritability, or odd behavior, may be misattributed or misinterpreted to normative teenage development or adjustment issues. It's easy to sweep it away and say, oh, they're just teenagers. They're acting like typical teenagers, when this is actually a cry for help. So clinical insights. Cognitive or social deterioration, abrupt changes in peer relationships, and functional decline should raise a red flag. So education becomes important to family members and clinicians when this family bring their adolescent children to you. This should raise a red flag so that you can evaluate for them. So early identification through school-based screenings and family psychoeducation can lead to better long-term outcomes. Coordinated specialty care programs. One example would be Navigate. It shows high efficacy in first episode psychosis. So if we do not find out what's going on early, we cannot provide these resources to the patient. So extensive assessment is necessary when teenagers or adolescents are presented to us with either mood symptoms or just difficulty in school. So let's talk about reproductive years. Remember, we're still dealing across lifespan. So during the reproductive phase, patients, especially women, face unique biological and psychosocial factors that affect both disease expression and treatment strategies. So for hormonal influences, estrogen has a protective role in dopamine regulation. So fluctuations during the menstrual cycle, pregnancy, and postpartum can exacerbate symptoms or alter antipsychotic pharmacodynamic. So postpartum psychosis, women with schizophrenia disorder are heightened risk. They are at heightened risk for postpartum psychosis. So we want to monitor these women that's had schizophrenic episodes before when they are pregnant or when they just have babies, because their risk increases, and it increases particularly within the first 2 weeks postpartum. Legal and child welfare systems often scrutinize psychiatric illness, leading to concerns over custody loss. And this can influence treatment adherence and disclosure. So what are the clinical implications? We want to choose antipsychotic medications with a favorable reproductive safety profile and involve perinatal psychiatrics in the care during pregnancy and postpartum. We also want to include psychoeducation and legal advocacy support. These are very important, especially when women have children, because they really panic that their situation is going to have some impact on the law taking their children away from them. As estrogen levels decline during menopause, symptom severity may increase, and the patient's response to antipsychotic medications may diminish. So clinicians have to pay attention to this when managing these women. So we want to understand where they are now, where they were before, and where they're going to. And this is going to guide in our treatment protocols. So when this happens, there has to be some form of pharmacological adjustment. Postmenopausal women may require dosage modifications due to increased sensitivity to extrapyramidal symptoms and altered pharmacokinetics. How about medical comorbidities? Higher rates of cardiovascular disease, osteoporosis, and metabolic syndrome also necessitates interdisciplinary care. Clinically, you want to consider switching to an antipsychotic medication that has a lower risk of tardive dyskinesia. Because you remember, due to hormonal fluctuation, they might lose that neuroprotectiveness or that modulation that estrogen provides. So it becomes necessary for us to either reduce the medication or switch to a different medication, because at the end of the day, we are managing schizophrenic symptoms, but we don't want to throw them into tardive dyskinesia. So you want to consider switching that antipsychotic. We can use the second generation antipsychotics so that we can mitigate symptoms associated with tardive dyskinesia. An example would be your aripiprazole or your pramiprazole. And we want to also collaborate with primary care or geriatric care teams for comprehensive care across lifespan. So culture, let's dig into culture. We've been discussing, it's a big, you go on media, we're talking about cultural syndrome. And in the United States, you know that America is a melting pot. It's a lot of culture here. So culture profoundly influences how schizophrenia is understood, how it is experienced, and how it is going to be managed. Stigma is a big deal when it comes to culture. In some cultures, schizophrenia is viewed as a spiritual thing. Somebody has been cursed by the gods, or somebody has done something in the secret and they're being punished. And this understanding increases shame. So a family member that may have a child may begin to hide this child, and this delays them from seeking help because the parents are ashamed, because people may perceive it that they have done something wrong and they are being punished through their child. And that can be a significant impact with culture. So when we are talking to people, we must be culturally sensitive. We want to understand, what does this mean in their culture? How about language barriers? Symptom expression, for example, hallucination or delusions, may be influenced by language or that traditional belief system. Another issue again is their healing practice model. Patients may turn to spiritual means. They won't come to you because of their cultural belief. And they might begin to go to church for spirituality because they think that it's an evil spirit issue. And when that does not work, they might go to traditional healers who have the ability in their belief system to communicate with the gods and see if there's an appeasement that can be done to reduce these schizophrenic activities, particularly in the African society. I'm African and I understand this very well because in my culture, it is frowned upon because they don't understand the medical aspect associated. It's a shameful thing. They see it as shameful. That child is hidden, or the family, sometimes they begin to think that that family is cursed. So, and this education, psychoeducation, we must provide to these individuals who come to seek help. Sometimes it becomes necessary to bring the whole family together and provide this education to them in a culturally sensitive manner. So what are some clinical recommendations? You want to use culturally validated assessment tools. For instance, a culturally formulated interview to talk to these individuals. You must be aware of their belief system. You must understand what they are going through, and you must be sensitive to their belief. Because if you rubbish their belief, they are less likely to come to you. And we can work together with these individuals while respecting their belief system and, of course, providing care for them. So we want to incorporate family and community leaders in the psychoeducation process because it will help build trust. They're going to feel, oh, you're not taking our child away from us in isolation. You are involving everybody. So we also want to employ culturally concordant providers, or interpreters when necessary. Somebody who understands what these individuals are going through, and be there and be sensitive and incorporate what they already understand, and we pretty much will work as a team to provide that care that these individuals may require. We have to destigmatize schizophrenia, even in practice. we are talking, there's stigmatization in media, and in clinical practice, there is stigmatization. So how do we destigmatize this? The power of language. Our language is so important. What are we saying to these individuals? How are we referring to them? So person first and strength-based terminology language profoundly influence how individuals with schizophrenia are perceived by society and how they perceive themselves. Problematic terms must be avoided. Labels like, oh, he's schizophrenic, or he's crazy, or she's crazy. These are reductive and they are dehumanizing. They conflict with the individual with the illness and perpetuate shame. It perpetuates shame and blame to that individual. So a preferred approach would be a person or a woman living with schizophrenia. We want to honor the individual's dignity. We want to honor their personhood, and we want to potentiate their recovery. So language influences treatment adherence. When an individual comes to you and they see you as a team player, they see you as being there for them, they see you as being respectful and understanding what they're going through, they are more likely to adhere to treatment and trust you as a provider. Patients who feel respected are more likely to engage in long-term management. Media portrayal and cultural narratives. From danger to resilience, women with schizophrenia are often misinterpreted in the media. They are depicted as dangerous, unstable, and incapable of functioning. So when other people who do not understand the disease process sees an individual living with schizophrenia, they are afraid because of what the media is saying. So such portrayals deepen societal stigma. It discourages help. It stops these individuals from seeking help. And it forces discriminatory practices, especially related to motherhood and employment. So what the media presents out there most of the time is not helpful. So we must figure out a way to promote recovery in the media. So focused media that show women successfully managing schizophrenia, pursuing education, and maintaining family roles or contributing to the workforce. If we support campaigns like Time to Grow that highlights lived experiences and resilience, this could be better ways to portray individuals who are living with this disease. When individuals have high blood pressure or they're dealing with cancer, media is so sympathetic with them. They seek treatment. So why can't we be sympathetic with individuals who are dealing with mental health? And we must promote media that sees mental health as self-care. And so psychoeducation, even for media outlets, has become very, very important. And studies have shown that clinicians are more likely to question parenting competence in mothers with schizophrenia than fathers. So that's another stigmatization right there. And this is coming from clinicians like me. So women may face over-medication or be prescribed certain antipsychotic based on assumptions rather than evidence-based assessments. So as a clinician, you are coming with bias that women have more problems and more issues. How can you be an advocate for them? So as clinicians, we must look at our own personal bias. We must begin to receive training on implicit bias training. And provider education combating bias requires active intervention within the healthcare system. So implicit bias training has become very important. We want to encourage providers to examine their own subconscious attitudes about gender. What are your thoughts about the women gender? What are your thoughts or your belief systems about womanhood or motherhood? And what are your beliefs or how do you see mental health or mental illness amongst women in general? So when we begin to reflect on questions like these and address these implicit biases, it has shown to reduce discriminatory language, increase empathy, and improve diagnostic accuracy. So trauma-informed gender-sensitive models, we want to train, training should emphasize women's unique risks, including trauma histories, reproductive health issues, and caregiving burdens. So let's go to community-based destigmatization. Lived experiences at the center of empowering women with schizophrenia to share their stories and participate in advocacy efforts is vital for changing public perception and policy. So if we delegate these women to the background and we're not encouraging them to come out there and talk about their lived experiences, how they have been able to survive, how they are functioning in the workplace, how are people going to know what's going on and provide support for them and understand that they are humans just like us, just struggling with mental illness, and they deserve the support and respect and not to be seen as outcasts in the society and deprive them of jobs or in cases of child custody battle, put their mental illness as number one instead of looking at the whole picture. So peer-led public education, women with lived experiences, they need to lead school talks, workplace seminars, or social media campaigns so that we can normalize psychiatric illnesses. Now, to a lot of people, psychiatric illnesses is a mystery. We have to normalize it. So how about family inclusive treatment? We want to involve families in psychoeducation and reduce stigmatization and reduce shame. It's going to improve support networks for these individuals, and it will, at the end of the day, strengthen the recovery process. What about workplace advocacy? Promote job accommodations and anti-discrimination policies to help women maintain employment and independence. Some of the programs are Women's Empowerment and Recovery Academy. We also have peer-led program that trains women in recovery to become mental health advocates. let me say that again, peer-led program that trains women in recovery to become mental health advocates. We have one Hearing Voices Network. It offers support groups that depathologizes hallucinations and elevates lived experiences. So let's look at a scenario, because women are often misdiagnosed, and we really have to lay a lot of emphasis in early diagnosis because the prognosis, the outcomes are always better. So Maria is a 32-year-old woman living in rural Nebraska. She was initially misdiagnosed with depression, and her auditory hallucinations were dismissed as just anxiety. Her family believed she was too functional to have schizophrenia. It wasn't until a telehealth clinician recognized her subtle negative symptoms that she finally received proper early intervention. Her treatment plan now includes gender-specific peer support and culturally sensitive family psychoeducation. Women are usually high functioning, and it is easy to misdiagnose them. And some of them who are experiencing depression, it's easy to diagnose them with psychosis that is associated with depression and leave out the diagnosis of schizophrenia because they are still maintaining their roles as wife. They are still maintaining their roles as partners. They are still maintaining their roles as caregivers to their elder parents. They are still maintaining their roles as mothers. So it becomes difficult because you see them as high functioning, and so they cannot be associated with schizophrenia. And remember that when they are not diagnosed on time and managed on time, long-term treatment may become challenging. So stigma remains a major barrier, preventing women with schizophrenia from accessing and maintaining effective care. Gender-based discrimination and internalized stigma often result in delayed diagnosis, poor treatment, adherence, and social isolation. So how do we mitigate this? So we must use validated tools like the MISQ, Mental Illness Stigma Scale for Schizophrenia Questionnaire. It helps clinicians identify internalized stigma and tailor interventions accordingly. You remember we talked about cognitive behavioral therapy, and these behaviors or learned behaviors that we have learned over time, it can alter the way we think. So we need, some kind of tailored treatment that can help with those faulty thinking or faulty thought process that we have learned over the years, either from home, from family, from society, that have shaped our lifestyle. We also want to include culturally inclusive resources. We want to offer multilingual psychoeducation materials and culturally adapted cognitive behavioral therapy workbooks to support engagement in diverse population. We also want to include peer-led and legislative advocacy. We want to connect patients to organizations like NAMI, SADA, or the Hearing Voices Network, and encourage involvement in policies addressing mental health and gender equity. So support networks are so important. Why? Because they facilitate family education groups to reduce blame and build understanding. Imagine in my population, in my family, or in my culture, where they think that having a significant mental health crisis like schizophrenia is associated with things that you have done and you are being cursed by God. Imagine how stressful that can be and how it's shameful to a family. And it goes on and on. That when a child of yours wants to get married in future, they will tell the people, this family are cursed. You can't marry into that family. Why? Because they don't understand what's going on. So family education, societal group education is so important so that we can reduce stigma, we can reduce blame, and build understanding. We want to offer women-specific therapy groups too that focuses on trauma, parenting, and empowerment. You know that schizophrenia has been attributed to some trauma or some maternal insult in utero, and of course, family history. So this holistic approach promotes recovery, reduces stigma, and strengthens access to equitable, gender-sensitive care. So what are the key takeaways? Early recognition, very important. You want to remember that women may exhibit a subtle, a calmer, or atypical symptoms of schizophrenia because we've been channeled to understand the highly heightened individuals, with schizophrenia that are showing those heightened emotions, strong delusions, disorganizations, and paranoia. So when you have a woman who's presenting with subtle or atypical symptoms, we tend to overlook it. So tailored screening tools and heightened clinical awareness are essential for timely and accurate diagnosis. Treatment equity. Effective care must address hormonal fluctuations. We are dealing with women. So when we are dealing with women, there must be that treatment equity. You want to pay attention that this is a woman and there are other things that we need to put into consideration when we are providing treatment. So we must put into consideration, we must address hormonal fluctuations. We must address reproductive health and the complex social roles of women. So individualized treatment plans are critical to achieving therapeutic equity. Destigmatization. Use person-first language. Integrate culturally sensitive care and uplift women's lived experiences through recovery. We want to use that recovery-centered narratives to combat stigma and foster engagement. So together, these pillars, early recognition, equitable treatment, and destigmatization, form the foundation for empowering women with schizophrenia across the lifespan. So these are some references that I looked into, and I hope this has been really informative and educative for you. And if you have any questions, we appreciate your engagement in exploring women's unique experiences with schizophrenia, please reach out with follow-up inquiries about gender sensitive approaches if you have any question. Thank you.